So thank you for inviting me and giving me the opportunity to present our data today. So the focus of my talk will be the targeting multiple inhibitory pathways. So what are, in our view, the important inhibitory pathway to counteract in order to improve the immune response to melanoma? So today I'm going to talk just a little introduction on the tumor antigen. I'm going to talk mainly today about NY-ESO-1 for New York ESO-1 is a cancer germline, also called cancer testis antigen. It's expressed by melanoma, roughly 30 to 40% of melanoma express it. It's also expressed by multiple tumor. So it's expressed by testis, so that's why people call cancer testis, but the spermatogonia do not express MHC class 1, so do not present peptide MHC complex to T cells, cannot be recognized by T cells. So some people say that it's tumor specific for this reason. One advantage, that's something we like about NY-ESO-1 is spontaneously immunogenic, so meaning that a number of patients will develop spontaneous T cell response to this antigen that can be detected and studied without having to in vitro do stimulation, which is very inconvenient for the study I'm going to talk about today. So our interest for immune checkpoint blockade in general for the mechanism of melanoma-induced immunosuppression stems for studies of spontaneous or vaccine-induced tumor cells in melanoma patients. So we run a number of trials. This is an example of a CPG trial with NY-ESO-1 peptide, class 1 peptide, in patients monitoring immune response pre and post-vaccine. And this is a free example. You can see that these are tetramer assays where we detect a T cell response, so no detectable immune response in this patient after 8 vaccination. So you can detect these T cells. It's done ex vivo. So amazingly, this is an example of strong spontaneous immune response to NY-ESO-1, like you can find sometime. We could amplify this response, double over time, a small response that increased. So this is, the schema, the kinetics of immune response in this patient, but in all patients, even if they had 8% of circulating CD8 plus T cells, recognizing specifically NY-ESO-1 that produce cytokine, all these patients progress. So it was a reason for us to try to answer the question why high level of tumor antigen-specific T cells, either spontaneously or induced by vaccination, did not correlate with clinical responses. So there are multiple reasons for that. So one may think that maybe a problem of migration. We do most part of a study at the periphery, so they may not migrate. That's a question we didn't address. We decided instead to focus on what could be the important mechanism of melanoma-induced T cell dysfunction in these patients. So when we talk about tumor-induced dysfunction, this slide I took from the chronic viral infection field, so the mechanism impeding CTL dysfunction are rather similar. So we know that a number of cytokine or molecule can be produced in the tumor microenvironment, including IL-10, TGF-beta, IDO that impede CTL. So we know, thanks to Soldano, that there may be some problem in terms of antigen processing, and the antigen may not be processed or presented, or tumor may lose HLH. It's a possibility. There is now knowledge that a number of suppressive cells exist in the tumor microenvironment, including the Treg, the MDC. And now there is also strong evidence that T cells, when chronically activated, will upregulate a number of inhibitors. PD-1 is the main example, but I think the family is growing, as I'm going to talk about. Ligands are expressed by melanoma cells, by tumor cells, and also by APC, and interaction of a ligand and receptor will impede T cell proliferation and induce apoptosis of these cells. So importantly, I would like to remind you the concept of dysfunction exhaustion as stated by Rafi Ahmed and this group. That show that in the context of chronic viral infection in mice, cells that are chronically stimulated, so upon repetitive TCR stimulation, will progressively lose their capacity of proliferate, of produce cytokine, of exhibiting lytic activity. So we call that these cells so-called exhausted T cells. And I think this concept has been proven true also in human. We can find these exhausted T cells in HIV patients, in HCV patients. So we were interested to find out. And I would have to add that most importantly, looking at this cell setting, these cells, we find that these so-called exhausted T cells would upregulate PD-1, which is one of the negative markers. So I'm not going to talk about too much about PD-1 today, so there will be a whole session dedicated to PD-1 tomorrow, just to remind you that it is expressed by the exhausted T cells and the activated T cells, and that the ligand, BCH1 or PD-L1, can be expressed by APC, antigen-presenting cells, or sometimes melanoma cells. So coming back to this patient with a spontaneous response to NY-ESO-1, and that had progressive disease, when we look at PD-1 expression several years ago, we could find that the large majority of these cells upregulate PD-1, in contrast to MART cells, so recognizing the melanoma MART antigen, or virus-specific cells isolated from the same patient. So this is a summary of data where we really find that both in terms of frequency, of intensity, of expression, so there was upregulation of PD-1 among the T-cell recognizing NY-ESO-1 ex vivo, but not in virus-specific T-cells from the same patient. So to study a little bit the implication of this finding, what we do is a blockade assay where we took the lymphocyte of the peripheral blood lymphocyte of this patient, and where we stimulate the cells for several days in the presence of cognate antigen, so the NY-ESO-1 peptide. And so if you take, for example, this patient who had 2.7% antigen-specific T cells to start with, after several days of stimulation, and as expected, in the presence of cognate peptide, you will have proliferation, so more cytokine. We are evaluating here interferon gamma. When you add the blocking anti-PD-L1 here, you add even more cytokine, so more cells and more cytokine. Here we use an anti-PD-1, which is not the anti-PD-1 used in the clinic. It's not the agonist, the antagonist, it is the agonist, so which activate the pathway and, as expected, less cells. So this is summarized here, where we really show that these cells not only express PD-1, but when we block the pathway and stimulate them in the presence of cognate antigen, you really are capable of expanding these cells. So one important observation that we did, so the data also true in terms of proliferation. So you have more cells that produce cytokine and more cells that proliferate. But one, I think, interesting observation that we made is when we look at among the antigen-specific cells, the cells that were functional, so we didn't increase the fraction of functional cells among the antigen-specific T cells, as if the blockade increased the survival of the cells, and we end up having more antigen-specific T cells, more cells that proliferate or produce cytokine, but as if we didn't really, on a cell-per-cell basis, increase the capacity of these cells to produce more cytokine, so as if we didn't reverse on a cell-per-cell basis the T cell dysfunction. And so this observation led us to try to find out if, by blocking of the pathway that we had to pick, if we could really not only increase prolong the survival of these cells, but also increase the capacity on a cell-per-cell basis to produce more cytokine. So trying to find out what other pathway we could focus upon, so the choice is big, and so there's a growing number of members in this negative regulatory family. We decided to focus on TIM3 at this time. TIM3 was known as a negative regulator of Th1 immune response in animal, mainly in autoimmune disease. There was no data in cancer yet. So the molecule has been discovered by Kukru. It is expressed by activated T cells. And the ligand is galectin-9, so at least one of the ligands. So there's a big discussion on this topic. And it's possible that other ligands exist. And galectin-9 is expressed by APC, can be also upregulated by melanoma cells. So when we look at this time on these tetramer positive cells, not only at PD-1 but also TIM3, we could see, for example, in this patient that 50% of the cells, the circulating T cells ex vivo CD8 plus T cells upregulate PD-1 and T3, co-express PD-1 and T3. So TIM3 by itself is not specific of these antigen-specific T cells, because you can see that the flu cells, the influenza-specific T cells in this patient express significant level of TIM3. But when you look at co-expression of PD-1 and T3, that's where you see this subset of T cells that is not present among virus-specific T cells from the same patient. So we try then to find out, so if these cells were dysfunctional. So what we do in this case is a short ex vivo assay where we take the T cells ex vivo and stimulate them with the correct antigen and do this flow cytometry, looking at cytokine production. And we could, focusing on this PD-1 TIM3 here, evaluate the frequency of cells that produce interferon gamma, TNF, and IL-2, and could find out that this number were much lower than the cells expressing either PD-1 alone or that were PD-1 and TIM3 negative. So the data are summarized here, where we see that both, so in terms of interferon gamma, but this is true also for TNF and IL-2, the cells that co-express PD-1 and TIM3 produce less interferon gamma than the cells that do not express PD-1 and TIM3. You can see also that the PD-1 positive alone are as good in terms of cytokine production most part of the time as a double negative, which really indicate that PD-1 is by itself is not a marker of T cell dysfunction, of exhaustion. We have to remember that it's also expressed by activated T cells. And so it's not surprising that, that T cell expressing only PD-1 but do not co-express other marker would be activated T cells that are really functional. So to try to find out the implication of this co-expression, so we ran the same assay where we took the PBMC, peripheral blood lymphocyte of this patient, and stimulate them in vitro in the presence of correct peptide and incubate them either with anti-TIM3 antibody, anti-PD-L1 blocking antibody in this case, or both of them. And you can see that using the anti-TIM3, the cells do a little bit better in terms of interferon gamma. They do also a little bit better than antigen alone in the presence of PD-L1, but they do even better when you combine anti-PD-1 and anti-PD-L1 anti-TIM3. So this is a summary of the data where you have a little bit more interferon gamma in general when you use both antibody, you have more TNF, and you have also more IL-2. So in terms of proliferation, the data are similar. So as compared to antigen alone, where when you use the anti-TIM3, these are the CFSC assay. So the lower CFSC cells are the cells that proliferate, and you can see that anti-TIM3 and correct antigen induce cell proliferation, anti-PD-L1 again the same, and the combination does better in terms of proliferation. So, but one interesting observation here, if you look among the antigen-specific cells, the frequency of producing cells or functional cells increased this time in contrast of PD-1 blockade alone, which indicate that we were, in this case, capable of improving on a cell-per-cell basis the capacity of these cells to produce more cytokine and to be more functional. So we also focus on other inhibitor receptor. So we decide to focus on BTLA, and the reason why we pick so a given receptor is mainly because we screen the T cells for the expression and decide to focus on receptors that are expressed by a significant number of antigen-specific T cells, the NY-1 specific T cells, and in this case, when we run a tetramer assay in combination of BTLA and PD-1, you can see that these cells, more than 50% of these cells, upregulate both PD-1 and BTLA. So this is a summary slide when we are playing with now with three markers, not only PD-1 and TIM3, but also BTLA. And I would just drive your attention on this two parts of the slide where you can see that as compared to virus-specific cells from the same patient, you can find a significant subset of cells here that are recognizing the antigen NY-1 that co-express PD-1, TIM3, as I previously reported, and BTLA. But there is really a significant, maybe the largest subset of T cells co-express only BTLA and PD-1. And this compartment is, at very low level or even not absent among virus-specific T cells. So trying to a little bit go forward and find the implication of this finding and find out if these cells co-expressing BTLA and PD-1 were functional. We run an ex vivo multiparameter cytokine assay where we take the T cells from this patient ex vivo, label them with tetramer and with BTLA and PD-1. So, and now we can focus on each compartment depending on BTLA and PD-1. And again, here focus here on this double positive BTLA PD-1 that do not express TIM3, and we could evaluate their capacity of produce cytokine, the frequency of cytokine producing cells. And you can see that this frequency was superior here to the cells that express TIM3. So these cells are only double positive, BTLA PD-1 as compared to BTLA PD-1 TIM3. So more cytokine here, but less cytokine than the PD-1 alone or the triple negative. So, and the data are summarized here. So on the one hand, so the most dysfunctional cells, I talk about the PD-1 TIM3, the BTLA positive, so we know about that. The cells that do not express this marker, that are the most functional. The PD-1 alone, again, and you can see that the PD-1 alone do a great job, as good as the triple negative. And then this subset here, which is BTLA and PD-1, but TIM3 negative, which seems to be intermediate. So in terms of production of interferon gamma, they produce more interferon gamma than the T3 positive, but less than the PD-1 alone or the triple negative. And the data were also true for TNF. So in terms of functional implications, so we run, again, the same assay where we take the PBMC and incubate the cells with coagulate antigen with each of the antibody, the anti-BTLA, anti-PD-1, anti-TIM3, and the cells do a little bit better in terms of cytokine, but they do better when you combine PD-1 BTLA or the triple blockade. So it's rather similar, so double or triple blockade here. Maybe the triple blockade may be a little bit better in terms of IL-2 production. So one important question is, do we find that at the tumor site? So we work in a model, NY-1, which is T cells that are present in the periphery. So in the tumor microenvironment, what can we say about the expression of this marker? So with the help of John, we get melanoma metastasis from a number of melanoma patients and run a flow cytometry. So we are working now in a polyclonal population, TIL population, looking at CD8 and the expression of this marker, and could find that we could find this subset of cells that could express either the two marker, so either the free marker or the only two of them here, the PD-1 BTLA are present, the PD-1 alone or the triple negative are present in the tumor microenvironment. So what about their function? So we had to stimulate the cells either with anti-CD3 or PMA, so as we don't know the antigen specificity of these cells, and evaluate by flow cytometry ex vivo their capability of produce TNF on IL-2, and could find that effectively the cells that express PD-1 and TIM3 and BTLA were the most dysfunctional, as well as the PD-1 TIM3. And again, the double positive seems to do a little bit better in terms of cytokine production, but were less functional than the PD-1 alone or the double negative or triple negative. And the same thing was true in terms of IL-2 production. So what we find for NY-1 at the periphery appears to apply also in terms of tumor T cell present in the tumor microenvironment. So they express this marker, and depending on the co-expression of some of this marker, we can define different T cell subsets exhibiting different level of T cell dysfunction. So what we recently extended our works to CD4 cells present in TILs, where we could show that this marker were expressed with one difference. We couldn't find a significant subset of TIM3 positive cells for some reason in these cells. So the largest subset is a subset co-expressing PD-1 BTLA with also a large subset expressing BTLA alone, which is not found among or are very low level among CD8 plus T cells, something we are still investigating. So BTLA, I think, is very interesting for one reason. So I was trying to make a comparison between chronic viral infection and cancer. A lot of things are, as I explained you, a lot of things in terms of immunoregulatory mechanism are really similar, and there is a lot of similarity in terms of the inhibitory receptor expressed by both type of cells. So now we know that PD-1 can be expressed by chronic viral exhausted T cells. TIM3, the following our work, I think the people in the chronic viral infection find also that the TIM3 was expressed by chronic viral exhausted T cells and show that they could enhance the capacity of these cells to produce cytokine by blocking PD-1 and TIM3. But interestingly, BTLA was not found as a marker of exhaustion in chronic viral infection. So I think that's an important distinction in between the two systems. One other, I think, interesting difference is the so-called marker of exhaustion are really expressed upon chronic TCR activation. And the higher the dysfunction, the higher the expression. This is the example of PD-1, where when you look at the cell that express PD-1 alone, PD-1 BTLA or the triple, so as I show you, the level of dysfunction increase with the co-expression, with the expression of this marker, and it goes with increased level of PD-1 expression. And this is true for TIM3, and this is what you expect from an exhaustion marker. They are really upregulated upon the chronic exposure of TCR. But we are surprised to see that the level of BTLA that didn't increase, with the dysfunction. So the level was rather similar, that the cells were less dysfunctional or more dysfunctional, right? Which was surprising to us. So how to explain that? So when somebody think about chronic infection and the mechanism leading to T-cell dysfunction, so I talk about the exhaustion, the chronic stimulation of antigen that induces T-cell dysfunction. And there is in the environment a number of immunosuppressive environment elements, which are the regulatory T cells, the myelosuppressive T cells, the cytokine. And we found also that in the cancer, there is chronic activation of T cells with huge exposure to antigen. The immunosuppressive environment is there. But I think one possible, perhaps difference, may be the energy, the capability of maybe infected cells to prime better immune response. And we know that in the tumor microenvironment, so the expression of co-stim molecule may not be great enough, and there may be what we call anergy, so a bad priming of cells that would produce less IL-2 and be dysfunctional. But this mechanism is different from chronic exhaustion, where it's really driven by TCR stimulation. So we are in the process of investigating that, and the way we try to do that is to look at the expression of a number of genes that are the so-called energy-associated genes. There is a panel of genes that have been that are known to be overexpressed by energy-associated gene, and we look at that. So this experiment that we do by a real-time PCR that show that. So here in this case, so I'll show you an example where we can show that the cells expressing BTLA seem to upregulate this marker ERK3, so much more than the cells that do not express, which suggests that, and the same thing is true for ERK2, so may suggest that and go in this direction that maybe BTLA may be a marker of energy rather than exhaustion. So this has some implication in terms of therapy. So we all talk about blocking this pathway, but if this is true, we may think about also immune intervention to prevent BTLA expression. So if it's an energy marker, you may think that maybe a good vaccine may prime cells better and maybe prevent BTLA overexpression by the antigen-specific T cells. So I talk about, so I'm going to stop here in terms of making a list of inhibitory receptor we have studied. So when we talk about inhibitory receptor, somebody may think, so what about the ligand at tumor site? And we know that several work has been published already in this regard. So we're interesting to look in these melanoma cells. So, and this is how we evaluate the presence of cells in the non-CD3 population. So we have used the CSPG4 antibody from solidoferone to label the melanoma cells and marker of myeloid cells or monocyte present in the tumor microenvironment. So, and when we look in this compartment, the expression of PD-L1, we say that the melanoma cell express high level of PD-L1 in this case, or variable level, but in general high level. So although there is a very low number of APC in the tumor microenvironment, they express significant level of PD-L1. So in contrast, the level of HVM, which is the ligand of BTLA, seems to be rather low. So, and in, I would say, in a correlation which has been published by Lieping Chen, so when we try to correlate B7H1 or PD-L1 expression with the number of CD8 plus T cells that we find in these TILs, there was a correlation. So the more PD-L1, the more TILs, and the thing was not true for HVM. So I just want to add at the end of the talk, so I focus my talk on exhausted T cells, spontaneous T cells that are present in this patient at the periphery or tumor site that upregulate this inhibitor receptor. So looking at the vaccine that we did, and this is the CpG vaccine I was talking about, capable of priming T cells. I believe that CpG is very likely one of the most potent adjuvants to date for cancer vaccine, capable of boosting a strong T cell response in this patient. But when we look in this patient vaccinated by CpG and peptide, not only at the frequency of T cell, but the expression of PD-1, we could see that with the increased frequency of T cells, there was also the proportion of cells, the frequency upregulating PD-1 increased. So which goes along with the frequency of T cells. These are activated T cells primed by the vaccine, and in a matter of months, the frequency augments, and in general, the majority of these cells here upregulate PD-1, while so a minority only here, I would say a little bit higher here, but upregulate TIM3. So these are functional T cells, so they produce cytokine. Some of them exhibit lytic activity. So that's, I think, a different thing than the exhausted T cells. So, and this confirms that functional cells and recently active T cells upregulate PD-1 and a fraction TIM3. So we are also trying to define if in the context of this non-exhausted but functional T cell that upregulate PD-1 and TIM3, we could enhance further their capacity of produce cytokine with anti-PD-1 or anti-TIM3 or both blockade? And the answer is yes. So taking these cells from vaccinated patients and applying in this in vitro simulation either the anti-PD-1 blockade, anti-TIM3 on both of them, we could further enhance their capacity of producing cytokine and functional. I think this is an interesting concept. So tomorrow we're going to talk about PD-1 blockade with fantastic results, and we already think what to do after PD-1 blockade, say if 30% of patients respond or 50%, what to do for the next one. It seems to have, there is a body of evidence that the non-responder to PD-1 blockade may be the patient with no immune response pre-existing to their tumor. And so everybody thinks that maybe that would be a place for the vaccine. So you vaccinate these cells, bring the T cells, and then so PD-1 blockade could work. But our work suggests that so PD-1 blockade and TIM3 blockade will also be needed when you have a vaccine to further promote the proliferation and the function of these recently primed cells by the vaccine. This will be also important, and this will go and I think suggest that you will have to at an early step combine PD-1 blockade and TIM3 with a vaccine. So I would like to end up here and conclude that we show, and I show you that there is a number of dysfunctional T cells co-expressing PD-1 and TIM3 and or BTLA. So I'm talking about dysfunction, not exhausted, because as I hopefully showed, BTLA is not a marker of exhaustion, but of dysfunction, possible energy. We still have to work on that. And that there may be a limited number of co-inhibitory blockade antibody may lead to enhancement of tumor-induced response to tumor. So PD-1 and TIM3 are marker of exhaustion, while BTLA appears independent of the level of, is expressed independently of T cell, the level of T cell dysfunction, may be a marker of energy. And I think there is a rationale for combining PD-1 and vaccine, not only to increase PD-1 efficacy, but also to increase the function and the expansion of the vaccine-induced T cells. So I would like to, so this is a model where we propose to combine. I would like to thank people who did the lab, so Julien Fourcade mainly in my laboratory, John, who has been really helping us a lot by providing all these samples, and a collaborator. Thank you very much.